some slides. Let me tell you from the beginning that we will deal with some specific maneuvers in order to make a diagnosis between these 5 types of regular supraventricular tachycardias: atrial tachycardia, AV nodal reentrant tachycardia, accessory pathway mediated tachycardia, or AVRT. AV nodal reentrant tachycardia can be of the common or uncommon type, and accessory pathways could be of a short or a long conduction time. Now, you all know that the key way to make the differential diagnosis between regular supraventricular tachycardias is to introduce TPCs during the tachycardia. Now, if we see an advance of the atrial activation when the HIF is refractory, then this makes the diagnosis of the presence of an accessory pathway. However, the issue is that this is not always the case. So the negative predictive value of this maneuver is low. You can perform the maneuver, don't see this response, but still an accessory pathway can be present. So that means that this maneuver does not always give the answer. And then something else has to be done. In this slide, I show you a number of things that we can do, and this is only part of what has been described over the years. Let me remind you that this is an old issue. We have been talking about this for more than 20 years now, but still it's interesting that every single year there are some new maneuver that is described. So this is still an active research area. As was said before, we cannot go over all these maneuvers, so we have selected some of them that we feel are particularly interesting. For each of these maneuvers, we will show you one slide first that describes the intellectual content and how to do it, and then we will provide some examples, because we want this to be a very practical webinar. So we will provide some examples, and along with examples, we will propose you some questions with multiple choice answers, and you will have the opportunity to vote. So let me go ahead and start with the first maneuver, and that is to compare the atrial activation sequence during tachycardia with the atrial activation sequence during ventricular stimulation. If these two sequences are identical, that provides the information that an atrial tachycardia is highly unlikely. And this is so because in AVNRT or in AVRT, there is a structure below the atrium at the junction of the atrioventricular anatomy that is related to the tachycardia. So when we pace the atrium, when we pace the ventricle, the atrium will be activated in the same way as during tachycardia because the same structure will be used. This is totally different if there is an atrial tachycardia present, because then conduction from the ventricle to the atrium will proceed along the AV node, and the resultant activation sequence of the atrium will be different than during tachycardia that is originating at any site. However, if the caveat here is that an atrial tachycardia can arise exactly at the AV nodal area, and then provide a similar activation sequence, but that is very, very rare. So let me provide you an example here. This slide is taken from the clinical electrophysiology textbook of Mark Josephson. So I call it from the Josephson collection. There are beautiful examples of beautiful tracings there. And this is one of them. In the right panel, let me see if I can show you here. In the right panel, you can see what happens during SVT, and I want you to look at the atrial activation sequence. And that means that we can have here, we can see here the coronary sinus, proximal, distal. We can see the high rate atrium, and we can see the atrium at the His bundle area. Now, please note that if we look at the events during ventricular pacing, you can see on the left panel that the atrial activation sequence is exactly the same as here. Please note the time interval between each pair of electrograms is identical. Don't look at MRA here. This has been displaced. But if you look at all the other four channels, you can tell also that even the morphology of the electrograms are the same. So as I said before, that means that when we pace the ventricle, the atrium is activated in exactly the same way as during tachycardia, right? So that means that there is a structure that is connected to the ventricle that produces an atrial activation sequence in the atrium identical as during tachycardia. So that makes very likely that there is a structure at the AV junction participating in the tachycardia. And this will not be expected to be the case if the tachycardia was in atrial tachycardia. Now let me show you now the next slide. Let me see if I can manage here. Yeah. And this slide, I want you to look at the right-hand side, and that is during tachycardia. All these are atrial electrograms. From the tricuspid annulus, these two, and from the coronary sinus, these two other here. And on the left panel, you see the events during right ventricular pacing. Okay? And I want you to compare the atrial activation sequences in these two situations, and I would like you to answer this question. Just looking at these two sheets and at these two atrial activation sequences, what would you think is the most likely diagnosis? Would that be AVNRT? Would that be AVRT? Or would you think it is an atrial tachycardia that is going on here on the right-hand side? I think we can, we would give you some time now to vote. As we heard before, you will have, I think, about 25 seconds to vote, and I want you to select one of these three answers, and then we will, the system will automatically count the voting for each of the three answers. Oh, that's fast. It appeared there. So 50% of you sent the correct answer. That is an atrial tachycardia. As it was presented to you before, and if you compare with the tracing I showed you, you can see that now when we pace the ventricle, just by looking at these two recordings from the tricuspid annulus and the coronary sinus, we can tell that it is different here pacing at the right ventricle as compared to the sequence during tachycardia. just this change tells us that the atrial activation is going through a different structure, okay? So this will be very unlikely, as I said before, that this is the response of a tachycardia involving an accessory pathway or an AV nodal reentry. Yes, I want to emphasize one more concept. This is particularly precise if the maneuver is performed during tachycardia, so producing entrainment of the tachycardia. Because if in that case, you can be sure that the structure that is used when you pace the ventricle to conduct to the atrium is exactly the same during pacing as during tachycardia, okay? If you perform the maneuver during sinus rhythm, when the tachycardia is not present, the maneuver can be misleading in some cases, for example, in the presence of an accessory pathway. As Fernando stressed before, you can send questions at any time during the presentation. Yeah. You wanted to make a comment, Fernando?
Yeah, sorry for interrupting, but this is a very nice criteria, and it's very easy to be used in the EP lab, because you only need to stimulate the ventricle for a while, and this is really affordable for every case. But there is only one comment I want to do, because in case you have a positive finding, as it is the case now, that there is a difference, what can see as a slight difference, but a difference, we have a positive finding. So definitely we can say that it is an atrial tachycardia. But in case we do not have a positive finding, we have to be concerned about the negative predictive value of the negative finding. Because it can be a negative finding, let's say the sequence is the same, or probably we have to consider that we have no sufficient recordings to make the difference. So this is a comment I want to know. Positive finding is always positive. Negative finding does not preclude the mechanism of the tachycardia. So probably you have some comments on that.
Absolutely. I think you are totally right. And obviously, this maneuver is more precise as we have more recordings. And also, it's important to have recordings at strategic sites. I think this is also important. And one site that is important in this regard is to have a recording just at the AV node area, just at the His bundle area. I think that is one important recording that could provide a lot of information. But exactly as you said, the more recordings we have, the more precise this maneuver will be. Absolutely. If we have only 2 recordings, as in this case, if we see the finding is okay, if we don't see it, we have to look more. We have to repeat the maneuver having recordings at other sites.
Oh, perfect. Thank you.
Thank you. Now, another interesting maneuver is to compare the HA interval during tachycardia and again the HA interval during ventricular stimulation. The intellectual content of this maneuver is represented in this schematic figure here. This represents what will be the finding expected in an accessory pathway-mediated tachycardia. Now, during tachycardia, let me see if I can have the ball here. Yeah, during tachycardia, there is a series of structures that are activated one after the other, and that is the His bundle, the Hess-Purkinje system. Now, part of the ventricle up to the ventricular insertion of the accessory pathway, and up going through the accessory pathway to the atrium. This is a ladder diagram. I hope you are familiar with this. We have represented here the atrium, AV node, Hess-Purkinje system, and this dashed line represents the accessory pathway. Okay, so this series of structures are activated one after the other and provide an HA interval that, as you can see, comparing with the situation during stimulation, you can tell here now that the HA is expected to be much shorter. Now, why is this? This is because when we pace the ventricle, the Hess bundle is being activated anterogradely. It's activated in the same way as during tachycardia, downwards, okay? And at the same time the Hess is activated, the conduction is proceeding through the accessory pathway to the atrium. So please note that now these structures are not activated one after the other, but are activated in parallel. The Hess is activated in parallel at the same time as conduction is taking place from the ventricle to the atrium. So now the HA interval is much shorter because it does not represent the activation of a series of structures one after the other. In contrast, the situation if in AVNRT, in avinular reentrant tachycardia, is different, because if the reentrant pathway inside the AV node reflects on the distal side, reflects right at the Hess, then the HA during tachycardia is expected to be the same as the HA during ventricular pacing, because the structure in between these two, between the H and the A, is just a fast pathway in the common form of avinular reentry. In the case that there is a lower final common pathway, that is, the reflection within the AV node of the circuit is above the Hess bundle, then in this situation, the HA interval during pacing is even less. So now you get a difference, but in the other direction. HA interval during tachycardia is less than HA during ventricular pacing. So the difference will go in the opposite direction as it goes during AVNRT. For this maneuver, as I mentioned before, for the comparison of the atrial activation sequences, the usefulness is maximal if it is performed by stimulation during tachycardia. And the main limitation of this maneuver is that sometimes when we pace the ventricle, the retrograde Hess bundle cannot be recorded, cannot be recognized. And the maneuver actually is based on the measurement of HA during pacing as well. Let me show you an example here, if I can go to the next slide, and I will show you an example. On the right panel, you see that in this situation we have been pacing at an area at the ventricle, but in the mid-septum, so we can record the Hess bundle, and you can measure the HA interval during tachycardia here is 240, but now when you compare the HA interval during ventricular pacing during tachycardia and entraining the tachycardia, now this is the Hess bundle signal here, and now the HA is 185. You can see it's almost 60 milliseconds less than the HA interval during SVT. Now this is a very, very specific finding in favor of an accessory pathway mediated tachycardia. Now at the left you can see what were the findings in a series of tachycardias that were looked at by Mark Josephson and his group years ago, and they found a neat difference in the HA during particularly septal accessory pathways here. As I said before, the HA interval is different than what is the measurement during avinular reentry as shown here on the left part of the slide.
Jesus,
I have no questions for this finding. Fernando, go ahead, please.
Yeah, just a comment. Sorry for interrupting, but you know this is the way I used to behave.
Absolutely.
So,
go ahead.
This is a very nice criteria because there is no overlapping, and I like it so much because of that. But probably you did a very interesting point, and that is that all these maneuvers that we do in the EP lab by stimulating are very, very useful in the case that only taking the sequences is not enough. Let's say, to differentiate a typical intranodal tachycardia from accessory pathway tachycardia mediated by a posteroceptal or paraseptal pathway can be very, very challenging. And in these cases, the sequence of activations probably is not all. We need a stimulation. So this is just to stress that point, because in this case, we can see how the activation is coming through the distal coronary sinus. But in all those cases that you stressed before, these maneuvers are really, really useful.
Absolutely. I mean, obviously, the activation sequence is very important. There's no question about that. But that is very important, for example, in this case, because it is clearly an eccentric sequence. But sometimes this is not the case. Or sometimes it's hard to catheterize the coronary sinus. Or sometimes, you know, the tachycardia appears when we are introducing the catheters, and the catheters are not in stable places already. So I think that these maneuvers have their role, absolutely, in some situations, and as you said, particularly when the activation sequence does not help. All right, so let me now discuss with you Parahisian pacing. Parahisian pacing, as you know, is a maneuver where you pace through a catheter that is located exactly at the Hess bundle area. At that site, when you pace with a high output, you are usually able to capture the ventricle, but also the Hess bundle directly. And as you lower, or in the case if you start by pacing with a low output, as you increase the output, eventually you can see that. So at pacing with a low output, you capture only the ventricle. Pacing with high output, you capture both the ventricle and the Hess bundle that is adjacent to the ventricular pacing site. Now, how can you tell that? You tell that, as you can see in this example, because the width of the QRS changes dramatically from one beat to another. What we are doing here is that we are pacing with a low output, and we increase, for example, from 3 milliamps. When we go to 4 milliamps eventually, we see a big change in the QRS, and not only the morphology, but particularly the width. Now, this QRS is obviously narrower than the QRS here. Now, what we have to do is to now look at what is the reflection of this change in the QRS morphology in the VA interval. If there is no abnormal structure between the ventricle and the atrium, when we capture the Hess, we will obviously short-circuit the structures between the ventricle and the atrium. So that will be reflected in a shorter VA interval as opposed to the situation with wide QRS that is not capturing the Hess bundle. And that will be an AV nodal response, and that will tell us that the situation is normal. Now, if you look at this tracing carefully, I would like you to answer this question. In this particular tracing, do you think that there is no, number one, no septal or paraseptal VA conducting accessory pathway, or number two, there is in fact a septal or paraseptal VA conducting accessory pathway, or you think that this tracing provides really no clues as to the presence or absence of a septal or paraseptal accessory pathway. Can you please vote in relation to this question?
I will use this time in the meanwhile to make a very an easy comment. So it's very nice how to see how when you increase the output, the width of the QRS gets narrower. So this is the clue that you are capturing the His bundle. But if you look at the right ventricle electrogram, you can see also how the interval in between the stimulus and the right ventricle interval also dramatically shortens. And that also makes the significance that you are directly entering the His bundle and then activating the apex much faster. So this is another funny way of checking that you are really stimulating the His bundle.
Absolutely, absolutely. That's a great point. You made a great point, Fernando. I don't know, can we see the results already, or can we have the voting answers? Okay, great. So the majority of the responses, 64%, provided the answer that this finding actually suggests that there is no septal or paraseptal VA conducting accessory pathway. I agree absolutely, because, and as you can see, the VA interval, just by looking at it, we can tell that this is much longer than this. Actually, the difference should be related to the VH interval. Since if we capture the His directly, then this will shorten by as much as the VH interval. So having a septal or paraseptal ventricular accessory pathway is actually, well, it's not suggested. What this actually proves is that there is conduction over the AV node. But let me now show you another tracing with basically the same maneuver. We are exactly pacing the same way. Originally, the first 2 beats here, we are pacing with a low output, and then as we increase the output, you can tell that there is a huge change in the QRS that is now much narrower. Okay? So then the same question will be asked to you now. If you think that, number one, there is no septal or paraseptal VA conducting accessory pathway, or that there is now septal or paraseptal conducting accessory pathway, or you think this tracing really provides no clues as to these answers. Can you please vote now? I think that despite having the answers there, you can tell in lead V6, you can tell that you can tell the narrowing of the QRS when you compare the last 2 beats with the first 2 beats. So looking at the atrial signal, what do you think? So now you are voting, and we will see the results here probably in a few seconds, so we can tell what is your opinion about this tracing. Very, very good. Now we got 89%, a great difference in your answers. So 89% of you think that this very, very short VA interval, and particularly because this really short interval does not change when the His is captured. That means that conduction was already taking place from the ventricle directly to the atrium through an accessory pathway. And the capture of the His is irrelevant to the VA interval. Absolutely, very, very good. Any comment, Fernando?
No, I like also to stress that even now the morphology of the atrium is not modified. So we can say that most of the atrium is depolarized through the accessory pathway. It's a very fast conducting accessory pathway.
Right, absolutely. Actually, it's impressive, impressively short VA interval. You must be, the pacing site must be really close to the ventricular insertion of the accessory pathway.
Probably Parahisian pacing, or Parahisian accessory pathway.
Yeah. Now, however, let me just make a comment that after having showed you these very good examples, I have to say, I have to recognize that I do not use Parahisian pacing routinely. I use it in special cases, but not routinely. And I have 4 reasons for that are displayed here. One is that the phenomenon cannot always be elicited. In other words, we sometimes do not see this nice change in QRS duration. Number 2, because what you have seen in these 2 examples are clear-cut responses, but it has been described that a variety of responses can also happen in terms that there can be some change in the VA interval, but not so big as in the first example. And that makes the interpretation difficult. Number 3, and I think this is very important, at best, it identifies the structure that is conducting. So that means that it identifies the structure with the shortest conduction time. But this does not exclude that structure with a longer conduction time could be in addition present. For example, in the first example, we showed that conduction was going through the AV node, but that does not exclude that there could be a slower conducting accessory pathway. And finally, the response, as with the previous maneuvers, is easier to interpret if it is performed during SVT. However, the catheters are also less stable during SVT, and the maneuver is more difficult to be elicited during SVT. So, again, this is a trade-off. Any comment, Fernando?
Yeah, there is a couple of questions dealing with the same issue, and this is how can we exclude that we are directly capturing the atrium with the high or the output at the His bundle catheter? How can we exclude atrial capture?
Absolutely, I think that this is also a great point. If the His bundle recording is actually proximal, it can capture directly the atrium, and that be totally misleading. So we have to make very sure that there is no direct capture of the atrium.
Yeah,
absolutely.
So a comment that I could say about that is that this is a dynamic maneuver. I have to say that you have to stimulate always through the distal pair, and you have to, in case you wonder about if you are capturing the atrium, you only have to push forward the catheter and test it. Because in these examples, you only have a fixed frame, but in the EP lab, you can really make the difference by moving the catheter, and you can check it, let's say, easily.
Good. Okay. We will move on to a different subject, and that is what we call the resetting entrainment response. And the first concept in this regard is to ask ourselves if resetting or entrainment with ventricular pacing occurs with or without fusion of the QRS morphology during pacing. As let me remind that when you pace the ventricle, you can tell if you are entraining a junctional tachycardia when the atrial rate goes to the ventricular rate, and both chambers are activated at the same time. When you are dealing with an atrial tachycardia, it's not so easy to make sure that you have entrained the tachycardia, but in any of these situations, you can ask yourself if there is fusion at the ventricular level during pacing. This is extremely important because if resetting and entrainment occurs with ventricular fusion, that indicates that there are like different sites of entrance to the ventricle and exit from the ventricle to the circuit. And these separate sites can only occur in the presence of an accessory pathway. And actually, we have shown years ago that this is the case when you have a septal or right free wall accessory pathway and you pace from the right ventricle. In contrast, if you are dealing with AVNRT or with an accessory pathway mediated tachycardia and the accessory pathway is left-sided, you will be able to entrain the tachycardia, but you will not see fusion in the QRS complex. The same situation will be present during atrial tachycardia, except that in this situation it is even more difficult to find out if you have really entrained the tachycardia, and actually this is even more rare here. Let me show you some examples. Look at these two tracings. I want to stress that in these two tracings that belong actually to the same patient, the same tachycardia, you can see the tachycardia on the last 3 beats of each of the tracings. We have performed ventricular stimulation during the tachycardia, and what you can see here are the last 4 beats of a patient trained at a cycle length of 330 in the left panel, at a cycle length of 300 milliseconds on the right panel. And let me stress once more that we are pacing exactly at the same ventricular site. The catheter has not been moved. However, if you look at the morphology of the QRS, when you pace at 330, when you pace at 300, please look at, for example, lead 2, lead 3, the morphology is totally different when you pace at 300 as compared when you pace at 330. Actually, if I tell you that we are pacing at the right ventricular apex, you should tell me here at the left panel, you are wrong. This is a wrong label. This is not the right ventricular apex. But in fact, it was right ventricular apex. So let me now ask you a question by looking at this tracing. What do you think is the most likely diagnosis here? Number 1, AV nodal tachycardia. Number 2, accessory pathway mediated tachycardia with a septal accessory pathway. Or number 3, an atrial tachycardia. Please vote for one of these 3 diagnoses that you think are undergoing the findings that you can see in the tracings. It's interesting that for this criterion, you don't need to see any intracardiac electrogram, okay? I'm not showing you any. I am showing you only the surface ECG. It's interesting, isn't it? You can tell just by looking at the surface ECG. So you are voting, and we can tell now the results. Okay, very, very good. 87% of you mentioned that this is a tachycardia that is related to a septal accessory pathway, because there is fusion in the atrial, in the QRS, in the surface QRS, and we can tell that there is fusion because the morphology is constant at each rate, but is different when we compare these 330 pacing cycle length with 300 milliseconds pacing cycle length. Okay, very good.
Okay. So
Fernando, any comment?
Yeah, let me stress this is a perfect example. Or let me go back to one of my prior comments by saying that in case of the positive finding, it's perfect, we are happy. But in case of the negative one, we should be cautious. So probably you will do on it. Yeah.
Absolutely. One very important thing to elicit this finding is to pace the ventricle with a very, very small difference between the pacing cycle length and the tachycardia cycle length. In other words, ideally, you should be pacing 20 milliseconds less than the tachycardia cycle length, or even less. Sometimes you need to pace 10 milliseconds less than the tachycardia cycle length to be able to elicit this maneuver. And it's sometimes easier to be seen with resetting, with a single ventricular stimulus. It may be easier to be elicited than with straight pacing. Let me show you the next example that on this green panel shows you the results of the study that we performed years ago. And as you can tell, the difference is very, very clear. As expected, it is impossible to have fusion with resetting in an avinual reentrant tachycardia. And this is so because there is only one gate between the circuit and the ventricle. That's a His bundle. It's a single gate. If you have a single gate, you cannot have fusion between reentry and structure, okay? So as expected here, all the cases had no fusion, either with resetting or with entrainment. With septal accessory pathway, you usually see fusion, but as Fernando mentioned, occasionally you may not see it. And that is because you are pacing too fast. You would like to try to pace as slower as possible. But sometimes if the tachycardia is not totally regular, for example, that could be a problem. Now let me show you this example now. This is an example of pacing during a regular narrow QRS tachycardia. You can see the tachycardia is represented in the last 4 QRSs and pacing in the first 3 QRSs. Now, when we, in this particular patient, when we paced at the exact same ventricular rate, but during sinus rhythm, in the absence of tachycardia, what we saw is shown here in this other tracing. So this is the resultant morphology of pacing from the same site at the same rate, but in the absence of tachycardia. Now, we come back to the previous slide, and I want to ask you this question. Having looked at the recordings, do you think that the tachycardia is most likely a left free wall accessory pathway mediated tachycardia? Or do you think it is most likely to be an atypical intranodal reentrant tachycardia? Now this is a difficult one, and I want you to look very carefully at this tracing, and eventually I will show you once more the previous tracing if I can come back, This is the morphology resultant from stimulation in the absence of tachycardia, and this is stimulation in the presence of tachycardia. You can compare the two of them, and now you should be able to vote only two answers for this question: left free wall accessory pathway mediated tachycardia or atypical avinodal reentrant tachycardia. What do you think is the most likely answer? Okay, very good. We got 71% of you said it was a left free wall accessory pathway mediated tachycardia. This is very, very good, I think, of you to mention that, because we didn't mention before that we could also pace the left ventricle. We said that pacing from the right ventricle, there is no fusion in left free wall accessory pathway mediated tachycardias. Why is that? Because we are pacing far away from the entrance site to the circuit, which is the accessory pathway. Okay. However, if we change the pacing site, we could now pace closer to the entrance to the circuit, which is the ventricular insertion of the accessory pathway. And I look at the morphology in V1. If you see this one, morphology in V1 represents obviously left ventricular stimulation, and that is why with left ventricular stimulation we can see fusion. The morphology of the QRS is different in relation of here during tachycardia as compared to stimulation without the tachycardia, which is the other tracing. Any comments, Fernando?
No, it looks a nice example in order to show the difference of the set of pacing, so I like it. So thank you, Jesus, for it.
I was cheating the audience because we said here right ventricle, okay? But since this is in Spanish, it wasn't that much of a cheating. Okay, so
only one comment. We have 10 minutes left. We should move ahead because I guess you have much more in the basket, but probably you should be aware of that. I am enjoying so much that the time ran fast.
Okay, so we will go just for one more thing, and that is the concept of corrected first post-pacing interval after entrainment. In this study, we showed that when we are in front of a tachycardia that has an accessory pathway as part of the circuit, then when we pace from the ventricle, we are closer. The ventricular pacing site is closer to the circuit. So usually the post-pacing interval is expected to be shorter as compared to the situation in AV-NRT when the post-pacing interval is longer than 110 milliseconds in most of the cases. Also, and along with this, if we look at the VA interval during pacing and compare to the VA interval during tachycardia, there is also a huge difference. Again, for septal or free wall accessory pathways, shorter difference, less difference, and higher difference for AV-NRT. Again, the cutoff is 110 milliseconds. Now, let me just show you this tracing, and I want you to now look at the post-pacing interval after pacing here during this narrow QRS tachycardia, and as it's written there, the PPI is 500, tachycardia cycle length is 320. Then we have corrected this difference by this difference is corrected by the difference in relation to the increase in AH due to the faster cycle length, and this is represented in the next slide that shows you now that the corrected PPI when we subtract the tachycardia cycle length is 140 milliseconds. It's longer than 110, and that is very likely to be an AV nodal reentrant tachycardia, which actually you can tell by the sequence as well. But what the example that I wanted to really show you is this next example. And here, I want you to look carefully at the PPI and vote in relation to the correct answer. What is the most likely diagnosis for this tachycardia? You can tell that the VA interval during tachycardia is quite long, and by measuring the intervals here, do you think it's an accessory pathway-mediated tachycardia, atypical AV nodal reentry, or atrial tachycardia? What would you think? I want you to vote now. We don't have a lot of time, so I think we have to be fast now. Can you please vote? You can measure the PPI in relation to the tachycardia cycle length, or you can measure the VA interval during tachycardia as compared to VA interval during ventricular pacing. And you could now vote, I think. And Fernando, I'm afraid that this is going to be
just a very fast comment. This is a very useful maneuver, not for the previous case that the diagnosis was evident, typical reentrant tachycardia, but for this case that we have the typical long RP interval. So these cases can be really challenging in the EP lab, and this maneuver is especially useful. So this is a good case.
Yeah, and also this is a simple maneuver. I want to stress that for the maneuvers we are commenting now, simplicity is important. Well, actually, we got half-half. We got half accessory pathway, half atypical AV nodal reentry. Let me just try to measure the intervals for you. I'm sure that you didn't have the opportunity to measure carefully the intervals, and that is why the answers are so distributed. But if you measure the PPI was 510 as compared to tachycardia cycle length 360. But I think it's important that in this case, the difference in AH is very significant, because in tachycardia is 140, but when we pace, obviously the AV node is activated at a faster rate, and that turns into an AH now that is 230. So now the correction, when you subtract the tachycardia cycle, you should correct for a difference between 230 and 140, and that is 90 milliseconds. So now you come up to a number of 60. 60 milliseconds goes in favor of an accessory pathway-mediated tachycardia. As you can tell now, when we see all the tracings, you can tell that now the activation was eccentric. The tachycardia involves a left-sided accessory pathway. You can easily tell now. But if you didn't have a coronary sinus as in the previous tracing, then this maneuver could have been of a great help. Also, if you measure VA interval during pacing here as compared to VA interval during tachycardia, you get about the same result, 60 millisecond difference, which goes very much in favor of accessory pathway-mediated tachycardia. So I don't know now, Fernando, if you want to sort of make a final comments, or what do you want to do?
Yes. I just want to thank you for all these beautiful tracings, all these beautiful words making the explanation. I really enjoyed. I hope and I expect that everyone did fun in the best way with this webinar. And the only thing I have to say now that I would like to come back and listen to all the more things you want to show. Just to say goodbye, I would ask you a final comment. We missed one question regarding what is exactly the meaning of fusion. If you are able to explain in 1 minute what fusion is, I guess we can say this has been a real success. Thank you very much, Jesus.
Thank you, Fernando. Fusion actually means the activation of a chamber by two different activation wavefronts. And it is crucial that that has to happen at the same time. So time is crucial. Activation of a chamber from two separate activation wavefronts that occur at the same time. Now, during entrainment, that happens because part of the chamber is activated in relation to the beat that has been actually paced now, but another area of the chamber is activated in relation to the beat that has been paced before. So the fusion takes place. Part of the chamber being activated by the N paced beat, and some other part is activated by the N-1 paced beat. And that is why fusion occurs.
So, Jesus, let me say thank you very much. Let me thank you to all the people who has been involved in the preparation and of this webinar. And let me thank you especially all those people who has been attending this webinar. Thank you very much to all of you, and I hope we can meet back in another webinar, because there are many more things to comment about supraventricular tachycardia. Thank you very much.